My name's Pascal. I'll introduce myself a little bit more in a moment, but welcome to the AI, Empathy, and the Art of Dialogue, a medical humanities workshop. This is actually a twinned workshop. So there was one last Wednesday that was on civil discourse, and today we're talking about medical humanities. The format is similar. If you were here on Wednesday, it's very similar. The content, of course, is different, but the concept of applying AI is the same, and the way we go through this workshop is also there's my dog barking. Um, Let me start with the land acknowledgement, if you please. So we'd like to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Wendat Nation, the Seneca, and the Mississaugas of the Credit. Today, this meeting workshop is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. So whenever you read this land acknowledgement, it's always interesting when it is a virtual meeting because we're not all in Toronto. So, but anyway, this is where the University of Toronto is, and so since we are hosting, then this is appropriate. Okay. Um, so who am I? I'm the Director of Data Science for the Department of Medical Imaging. I'm an AI researcher. I'm also the Director of EDIAA for the Institute of Medical Science, and I have a bunch of other affiliations, but I'm gonna pass right through that today so we can get into the fun stuff with Sarah. I do have disclosures. Once again, I'm in industry, I'm in AI, so no surprise, I have disclosures. There they are for you. Um, I've just said who I am. There's a lovely picture of me. Yay, fantastic. Let's get to the important stuff. So what are we doing today? We get an intro now. Fantastic. We get a wonderful keynote presentation. Well, actually, hopefully a wonderful keynote presentation. No, I'm kidding. We have Sarah here who's fantastic and will be telling us all about medical humanities. We will then move on to the fun stuff, which is the LLMs, the use of LLMs, and we actually have a live demo for you. So if you'd like, I can share in the chat, or actually I'm going to ask Arya, please, if you could share in the chat the link to what, the live demo area so that, people can have a peek at it quickly when they have a minute, and so that they know that they can connect to it afterwards. Then we'll have an interactive practice session that we'll have the pleasure of working with you. We'll decide whether or not we need a break, and then we'll have a debrief and discuss, of course, and then our closing remarks, and that's the end. So very, very straightforward, very typical, workshop format. So Sarah Kim, Dr. Sarah Kim, Assistant Professor in the Department of Family and Community Medicine, of course, at U of T. She serves as Health Humanities Theme Lead for Medical Education in our wonderful faculty of the Temerity Faculty of Medicine, and also a Director of the program in Health, Arts, and Humanities. So as a physician, she specializes in narrative medicine, sports and exercise medicine, and medical psychotherapy. Her works integrates the arts, humanities, mindfulness, and movement education to support resilience, ethical practice, and compassion-based care. Her scholarship examines high performance cultures and historical understandings of the body, with particular attention to power, relationality, and humanness within industrialized systems. She's also the former lead physician for Canada Basketball Women's Elite Program. Love to hear about that. Spending a decade traveling internationally with the national women's team. What a great experience that must have been. And alongside her medical work, Dr. Kim is an independent dance artist and somatic arts educator with a 2-decade interdisciplinary practice spanning contemporary and urban dance circus, another interesting topic to discuss, martial arts, improvisation, poetry, and prose. So on that note, absolute pleasure to host you, Sarah, and I can't wait to hear your presentation. So please, the floor is yours.
Great. So I'll just begin by, I'm going to share my slides, Pascal.
Please,
So I
of
think
course.
we will.
Please do.
Okay, can everyone see that?
Not yet. It's
Okay.
coming. There we go. Yes.
Wonderful. And so from the get-go, thank you, Pascal, for that lovely introduction. And in this part of the seminar or workshop, I designed it to make it as interactive as you can for a virtual webinar. And so with each image that I show, I invite you actually to notice the impact with which it lands on you, whether you can describe what it is or not. So if you notice any skin sensations or just even emotion come up or thoughts, just to notice that as I go through the various slides, because I do strategically choose them to be evocative in some way. And I actually really love this series by Fernando Vincente. It's a whole series where he does these anatomical drawings, but in a manner where it's also overlapping with fashion for some of them. And they're just very fascinating in terms of the emotive quality. And in that a lot of medical illustrators have quite a long background in arts. But what we're going to talk about is what is this idea of transformative paradigms? And because that's really where the discipline or the practice of health humanities lies. There we go. So to disclose, I am employed by the Temerity Faculty of Medicine as the Health Humanities Team Lead. I don't have any other tech companies like Pascal, but so mine is pretty plain. But if you feel like there's some kind of bias here, please do let me know. The one thing about land acknowledgement is that what I do for a lot of my learners is to use it as a reflective practice, because we all have different kinds of relationship with land. Whether you immigrated to that land or your parents did, or whether you have generations that have been part of your land. And thinking about, some of the difficult history, in particular in Canada, I do ask learners to think about the difficult history that the medical and healthcare system has had with the Indigenous populations here, and how it continues to be something that we need to reflect on. So I encourage all of my learners to think about the land acknowledgement as a reflective practice of who they are, where they've come from, what history they have living in Canada or Toronto, or wherever they happen to be calling in from. So today's objectives, I'm going to just introduce a few things where we're going to critically analyze essentially intersectionality in health contexts, and how health and medicine and all these things are actually socially constructed, and why there are overlapping things around culture and politics that are inherently embedded, and then how we navigate that. We're going to describe how key competencies in health humanities and narrative medicine map directly on what's called the CanMEDS rules, which is our guiding document on what a medical expert should end up being. And then we're going to look at, as we move through this webinar, the role of advanced technologies such as large language models in shaping or helping to shape health experiences, discourses, and health professions development. So I like starting a lot of my talks with setting the scene. This is a poem written by a pediatric anesthesiologist named Connor McDonald, who's based here in Toronto at Sick Kids Hospital, and he wrote this poem. See a family huddled at the OR door. Their father, an organ donor, declared brain dead 2 hours before. His name neatly printed on the OR board, but under the heading, procedure to be performed, one word, harvest, scrawled in Sharpie. And just as you either read that or listen to that, thinking about how that lands with you, where the family of this person see what's written on the door of where their loved one's body is about to be taken in, they see the word harvest. And so I often open just to get things, settled in around what we're going to be talking about more of why this happens. So I'm going to play a brief clip of about 30 seconds. This movie is called The Doctor. It was filmed or shown in 1991, where it is about a doctor who is sort of that typical, has that typical arrogant reputation of not being so great. And it is really around that person's experience as they move through the healthcare system. But this clip shows very well like what problem we're trying to deal with as we explore the health humanities. Sorry to keep you waiting. Busy day.
Jack McKay.
Yes, I know. Have a seat.
Right. Murray Kaplan sends his best.
Well, that's right. You're in practice together.
So we get it right.
So what seems to be the trouble?
What? Nothing. I mean, I have a tickle. I've been hoarse.
Take a look. Cross your knees, sit back in the chair. Sit up, hands on your knees, chin forward. And open. Let's take a look. Close. Open. Open. Right. Open. This might be a little bitter.
That's an anesthetic.
Want to take a closer look?
Whoa, a periscope.
Won't be pleasant. Tongue out. All the way. And hold it. With your hand. Head forward. And open. Right. And so just pausing there, thinking about this is a educated individual who speaks English, also has a sense of what might be happening, but thinking about contextually of a lot of patients that come in that have no clue what's about to happen, may not speak English, and are probably terrified. And this is not an uncommon kind of encounter that they tend to experience. So the health humanities is a broad transdisciplinary field. This is a very lengthy definition that I took from a website that the Health Humanities Consortium has. But it's really talking about intersections and looking at it from different perspectives of the humanities and social sciences studies, as well as things around the arts. So we see that there's intersections of literature, art, philosophy, ethics, histories. There's also, this list actually is quite broad. And, but there also, it's just very useful to try and think about it as, what does this teach us about human relationship and interactions, and what has been happening in our healthcare systems? So I like showing this one to especially early medical learners and trying to identify, do you see something that's unusual in the painting of this individual? And most people can identify that she has quite a large mass in her throat, which, back then, before they put iodine and salt, there was a lot of thyroid disease present. And so it gives a little bit of a way to give context of like all the historical things that have changed, but how art has actually captured these really interesting moments in medical history as people drew their representations. And then we have a conversation of like the person looking directly at you of why they might be doing that. So I'll get a little bit into that later on with some of the other slides. So classically in healthcare professions education, it tends to fall under behaviorism and cognitivism in terms of cognitivism, the paradigm of education. And what you get more when you're doing things in the health humanities is trying to move into the latter three of social constructivism, humanism, and transformative paradigms. And so what does that look like? So one exercise that I'd like to try with you is thinking about Bronfenbenner's bioecological model of human development, and thinking about how that can really offer an exercise of what factors have influenced your individual identity development, both personally and professionally. And we're going to go into more detail about that, but understanding that we as individuals exist within systems. We exist within a microsystem of our immediate environments. There's a mesosystem, an exosystem, and then there's this macro system, which can change over time. And it's a fascinating time right now as we're in the intelligence age, and where these relationships with technology are just rapidly shaping our understanding of the world. But thinking about for yourself the various factors that have influenced your identity development. And so one other thing, I'm going to take it a step further, is I'm going to get you to draw yourself a family tree. So what we call genograms, we often use this when we're trying to trace genetic patterns in families. But what we're going to try and do instead here is trying to draw out your family tree, but then tracing emotion patterns of way you cope. Like, is there an anxious side to the family? Is there a side of the family just talks and talks and talks? Is there a side of the family that can never talk about emotions? So just noticing that for yourself. And here's a diagram, if people don't know what a genogram is, of where, to the bottom left corner, you see yourself, you place yourself and your siblings, and then you trace it upwards over generations, mapping out the different relationships. So classically, if a person gender identifies as a woman, it's sometimes it's a circle, sometimes it's a triangle, and then males or men are represented as squares. The X's often represent that the person has passed away. But for yourself, taking a few minutes just to draw out your family tree and think about the various behavioral or emotional patterns that you notice as you do that. And I'll continue to explain why. So Disney actually put out this really great movie called Inside Out. People with children may have seen it because it's a kids movie. And they really made explicit of like what's going on in people's heads in thinking about the behaviors that actually manifest versus like what people have in their heads. And we can all relate to this. One example I often give people is that in a professional or academic setting, you're one individual, but then for some reason, when you go home to visit your parents, you somehow regress into either your teenage self or an earlier version of yourself when it comes to interacting with them. So this is just starting to like tap away at this idea of the internalized behaviors and culture and the values and then the patterns of behaviors that are passed through generations, and arriving at a place of being able to emotionally differentiate what sometimes is called emotional intelligence, emotional quotient, and we'll get into that a little bit more. But I'll play a short clip of this just to show you what most people do experience, but this cartoon version really makes it easier to understand. We'll just fast forward.
I don't know.
Oh,
Do you
here we
ever
go.
look at someone?
How was the first day of school?
It was fine, I guess. I don't know. Do you ever look at someone and wonder what is going on inside their head?
Did you guys pick up on that?
Sure did.
Something's wrong. We're gonna find out what's happening, but we'll need support. Signal the husband.
With a nice pass over the reed, comes across center ice.
Uh-oh, she's looking at us. What did she say?
What? Oh, sorry, sir. No one was listening.
Is it garbage night? We left the toilet seat up. What? What is it, woman? What?
Signal
Oh.
him again.
Ah, so, Riley, how was school?
You gotta be kidding me.
For this, we gave up that Brazilian helicopter pilot?
Yeah. So again, this is why I use film in a lot of my lectures, because sometimes just in that 30-second clip, you get very clearly an understanding that, yes, there's stuff that we have internalized, and how does that affect us in terms of professional performance? So the health humanities and narrative medicine have some core competencies. The first, one of them being critical thinking. 2 is reflexive capacity. So when you're having a difficult interaction with a colleague, for example, what is it that's driving your reactivity? What is it about them? And that's reflexive capacity there. The narrative competence is about understanding that when you're having a disagreement with someone, it's when 2 opposing narratives, or maybe not all opposing, are colliding, and you're trying to arrive at some kind of cohesive and perhaps collaborative story. The aspect of visual literacy I'll get to a little bit later on, and then how this ties into self-care and resilience, in really trying to say, if you understand your own personal history, and are able to understand that others carry histories with them, there's a lot more clarity that can arise around what are the things that are impairing your ability to have boundaries around what comes in versus what you're able to leave on the outside. And this, again, is how I did this. I actually made this representation and sent it to the Royal College to say, I think this is the way. We need to make at least a 3D or 4D model of what you expect the medical expert to be, because the 2D is too flat, and it doesn't allow for that complexity and understanding that it's actually weaving and changing shape and shrinking and expanding. But at the heart of it, what we agree on is that we have some core values that we hope that physicians, when we produce, well-functioning medical experts, at the heart are anti-racist, they're humanist, they have humility, and then they value these things around equity, diversity, and inclusion. That's what we hope for. In any case, so that was, that's just something as an image I'd like you to keep in mind. So I'm not going to play this video, but one of the big problems in medicine has something to do with ego. That historically the way we're trained is we're trained as an expert who goes in as the knowing person to tell the other person what the problem is. But what that has led to in terms of other patterns is that often we go in already with a preconceived notion of the other person. So one big example that this individual gives in the video is he talks about fibromyalgia. You pull out the chart, you see the word fibromyalgia, and automatically you're like, oh, this is going to take forever. Oh, this patient is going to, go on and on and on. But what we've done at this stage, and it's modeled in teaching settings, is we've shown contempt of arriving at judgment before even allowing space for the investigation. And so this whole idea around contempt prior to investigations is something that I talk a lot around the hidden curriculum. So one other thing that the health humanities is trying to address is, what do we learn by these nonverbal cues, and sometimes verbal, but behavioral cues that are demonstrated to learners that actually go against the values and priorities that we have written on our website around treating people with dignity, showing compassion, being open, being inclusive, being even just respectful, and and tying into last week's presentation, just going out beyond civility, but actually being people who are open to hearing other people's perspectives. So it's again, who or what. So when we think historically of where medicine came down the from about it was 1910, where there was a document called the Flexner Report that established medical institutions in North America. And Flexner was a German educator. At that time, though, what was very popular was this idea of eugenics, that there are different classes of races. It's also a time where women are still second-class citizens, that misogyny is a very common thing. So all these kinds of behaviors towards different peoples are embedded into the system still. And then thinking about for yourself culturally, as you think about your family tree and then all those external influences that you have in Bromfenner's model of identity development or human development, of what has influenced your own world view. So again, your professional identity, how's the world shaped you? Either explicitly or implicitly, what have you been told, who you need to be? And then, is this congruent with who you feel you are? So this is a quick clip of how quickly our brains move to assumption in order to be able to organize our world. So just show a quick bit of this. And so it's just, again, another way I use things to illustrate to the learners, because they often say, I'm not, I'm aware of my biases, I know when it's happening, but often we don't. And so, the the study of the critical health humanities is really trying to get to that we are constantly making stereotypes. This is a campaign that was actually put out by the Canadian Down Syndrome Society, and it's a fascinating. Just in the interest of time, I won't show. Actually, I'll show just the beginning, because the only thing I disagree with this, and I have to say this, is they kind of glamorize alcohol culture, which I don't. It's just a personal thing, but you'll see what I mean when they with the opening thing. So.
Hey, bartender, you assume that I cannot drink a margarita, so you don't...
Oops, sorry. I'll go back. Try that again.
Hey, bartender, you assume that I cannot drink a margarita, so you don't serve me a margarita? So I don't drink a margarita. Your assumption becomes reality. And parents, you assume that I cannot live on my own, so you don't encourage me to live on my own, so I don't live on my own. Coach, you assume that I cannot hit harder, so you don't train me to hit harder, so I don't hit harder. And teacher, you assume that I cannot learn Shakespeare, so you don't teach me Shakespeare.
Old MacDonald had a farm.
So I don't learn Shakespeare. E-I-E-I-O. But hey, if all your assumptions become reality, then assume that I can drink a margarita. Will you serve me a margarita? So I drink a margarita. Assume that I can live on my own. So I live on my own. Assume that I can hit harder. So I hit harder. Assume that I can learn Shakespeare. So, what fools these mortals be? I learned fucking Shakespeare. You assume I can't swear, right? Assume that I can do that job. That I can go to parties. That I can have sex. That I can be on stage. Assume that I can. So maybe I will.
So that was, I thought, a really great campaign that this actually really lands with the learners, because a lot of them suddenly realize a lot of the assumptions that they carry that have been informed by broader culture and also the learning environment. So again, there's a lot of things around being able to really see the full picture. So some of the things we do around looking at art pieces, looking at photography, looking at film things are related to trying to think through what is a critically thinking medical expert, someone and who can recognize that they have cognitive bias and accept with humility that we have inherent fallibility around this. A lot of this also ties into things around education, medical education, which is based in fear and shame. Either fear of making a mistake, fear of looking like you don't know something, but also carrying things around you as an individual of trying to hide. So there's a lot where we have faced things in throughout our school years that make us not be able to actually talk about when we are not understanding. So there's a lot of things that you're presenting as someone who might know, and this then carries through in the clinical environment where the patient might ask you, "Well, what do you think, doc?" And some people won't say, "Well, we don't actually know that." It's a really hard statement to make versus understanding that a lot of things in our current understanding of the body are still theoretical, and that there's a lot to move through. So I also talk through a lot of fear narratives in some of my classes, and this is Dr. Dan Siegel. He has this great video that's called Name It to Tame It, is where when you can directly identify whatever you're experiencing, you actually help to bring yourself out of a fear state and be able to evaluate it more with a more objective lens. And this again brings us back to this problem of contempt in medicine. There's a couple of misconceptions that the body is an object rather than a person, what people feel. They feel like they are objects that are simply being processed through a system. But the other thing that medicine has done historically is that emotions are a place of shame, rather than acknowledging that medicine is inherently emotional. When you are dealing with people, person to person, every moment is actually potentially emotionally charged. And we can't separate the body from the person, and this is what we've felt in our system, is that there's been this disconnect. So a lot of, again, this critical health humanities is trying to understand what is it to actually skillfully navigate an emotionally charged environment. I just throw this in there because it's like quite a striking image that was drawn during the pandemic. of how a lot of healthcare providers felt, suddenly as the heroes, but then relegated to not feeling like the system was supporting us anymore. There's other examples I give again from the same movie, The Doctor. Part of it is because it is a nice snapshot of historical behaviors that we are actively trying to change. Another one that I often use up is the movie Knocked Up, because there's a great scene with the physician, a physician-patient interaction, which you laugh at, but you suddenly also realize that that's what happens a lot of the time. And what we're trying to get at here is looking at, what does it actually mean to treat a whole patient? And can the technology, so one thing that's really exciting about these large language models and these AI-driven tools is that they can actually be programmed in a way or prompted in a way where it can support development. Because one thing that we notice learners will do is they will ask embarrassing questions to a machine that they're afraid to ask in person, or they will call things out to a machine that they're having discomfort with. So there's this really beautiful opportunity for it to fill a gap in a place where people can ask places of shame. Like, maybe I feel like I'm being canceled. Like, who's going to say that? But they will say it on, they will type it in. So again, there's really wonderful opportunity to, again, unpack. And I love this diagram of unpacking the layers of society and your, even smaller cultures that exist within you, that's related to the various systems that we live within. So a couple of the takeaways is that art is a means. I see art as a means. It's a means to question, innovate, advocate, give voice, but it's also an opportunity to transform. And that's what art does quite a bit for individuals, is that you can take it and make it into whatever you want, and it's your own personal expression. And another takeaway is that stories are how we communicate. As clear as we ever want to be, what colors the way we communicate is how we understand our views of the world and the other, and how can technology support more compassion-based narratives? Because ultimately, we're trying to work towards a compassion-based system, which again allows for more resilience as we treat each other with a greater understanding of our own humanity. And so I think I'll just leave it for there. There were a lot of things that I wanted to shoot, but I'm curious about the discussion and questions that are out. And this is my email if anybody has further things that they'd like to discuss. That's it.
Well, thank you very much, Sarah. Always very thoughtful. Aria and I had the pleasure of attending one of your workshops a few months ago now, I think, which was wonderful. And what a fantastic introduction to the topic today. And you actually, thank you, plugged it into technology and to LLMs, so couldn't ask for better. I think at this point, if anybody has any questions directly for Sarah, maybe ask them now. I mean, I'm hoping Sarah will hang out for a little longer in the workshop, and we'll get some hands on. But would anybody like to ask a question now directly from the talk? Anybody? No? Anyway, you can think about it, and you're welcome to put it into the chat at any time as well. And I think there is even a question button. I can't remember. Q&A that you can ask as well. Because I gave you the permission to speak, you can also put up your hand and ask the question verbally. So you have all of those options, and we're happy to accommodate you that way. I think we'll transition into a little bit more of the tech, but I'll just also say from your presentation, Sarah, I love the clips, by the way. That's fantastic. I couldn't agree with you more in terms of how impactful, especially if you know the movie, right? That you're bringing to your presentation. But also that clip on the Down syndrome, I knew very well because I've worked with persons with intellectual disability for about 40 years. So I know that clip very well. And it is, you make an excellent point, and especially actually, well, I agree with you about the drinking. That wouldn't have been my choice, but anyway, but apart from that, it was a very impactful, campaign, and very interesting. So absolutely, yeah, great things to think about from your talk for sure.
I'll
Uh,
just I'll
oh,
address Janet's question. She wrote,
oh,
"Can the
sorry. Yes.
current pedagogical methods and the time provided yield this type of teaching and learning?" So what we're what we're navigating right now is how to, I get 5 core lectures with the medical students in their first couple of years. And then what we're trying to do more is more embed this kind of content so that it doesn't necessarily take away time from the core technical teaching, but just frame it differently so that the learners are then prompted to think about this in the context of which they're already learning. The stuff they're really, they're very excited. In the first day of medical school, they just want to learn about the body. And so it's more just trying to meet the learners of like what they're excited about, but then give a little bit of a twist for them to start saying, well, all the things we understand about the body are socially situated and constructed. And there's lots of things that you're going to learn now that aren't actually going to be true in potentially 10 years from now. Like we'll have discovered something else new. So to also bring in that a bit of humility of just understanding how much we're still theoretically based, and that as the world continues to move, that lots of things will change. So the time is always an interesting question, like how much time? I think it's actually more of a design flaw versus time exposure flaw. And that's something that we're just, again, trying to address. Reza or Riza, sorry if I said that incorrectly. So you think there is a need for qualities like empathy and medical communication? If so, why? Some physicians might say, so that's such an interesting statement. So most physicians are actually inherently empathetic. It's just that during your training, it's stamped out of you. So we have we actually have studies to show that most medical students enter who have a very high level of empathy, but something happens during training where the empathy decreases. And part of it is, again, addressing what the environment is, but what is also modeled in terms of understanding, like, what does it mean to have an empathetic response? And also the conflation of objectivity, meaning no emotion, because that's not actually true. If you're actually able to understand and regulate your emotions effectively, you are much more objective than the person who's trying to suppress it. So what's modeled historically in medicine is a suppression of emotional response and empathy versus being skillful at, in that moment, what is a way that I can respond that's actually from a regulated place versus me feeling shame around having these emotions to begin with. So it's more of a change in understanding of what medical, and the other thing that's going to drive it is that as AI and these larger language models, these other technological tools start to facilitate the technical components more, there's an argument that what's actually critical is that we improve on our medical communication in being able to be a human, like a human to human, more translator or skilled in that space. So and then there's a whole other category of like who gets chosen to be in med school to begin with. Like perhaps those who aren't as empathetic because they're on a different kind of continuum of emotionality, perhaps they're better suited for research. And we should actually be leaning towards those who carry more space for that. Or is there a way to train it differently where it isn't seen as a burden, but as a way of facilitating? Because what the evidence shows is that physicians who actually demonstrate more empathy and being with the patient also tend to have less negative results in terms of error due to communication breakdown. So, yeah. Great.
Excellent. There's a question in the question box, but I'm
Oh,
going to actually pause on that one because we're actually going to address that. So then maybe we can answer it at that time if that's
great.
okay.
Yeah, sounds
Because
good.
literally we're going to talk about that. So that's fantastic. So thank you very much for that. I am going to just go through a few slides about the LLMs and all that fun stuff. For those of you who attended on Wednesday,
You're muted, Pascal.
so sorry, I just dropped, and it happened. It happened last Wednesday too, and I'm just like, what? Anyway, so my apologies. Let me share again. Just gonna find. It's every time I try and share, I think it or switch the sharing, it drops. Like it's a little bit annoying. Anyway, but I think we're okay, right, gang? For Aria and Thea Grace, yeah, we're good. Everyone's still connected. Everyone's good, or yeah. Okay, that's awesome. So I'm just trying to let me just check on our participants because I think I'm seeing people drop off and come back on as well, the participants. So I have a feeling it's the same thing. Okay. Anyway, once again, I was saying, my apologies that, I am going to repeat a little bit from Wednesday because inevitably some of you didn't attend Wednesday, but pay attention because I have changed it up a little bit. So it is going to be different. Okay, so let's just talk about LLMs a little bit. This is just a nice picture to show you the relationship between what AI is, artificial intelligence, which basically, the whole field of, let's say, computer science, creating systems that are capable of performing tasks that we would consider typically require human intelligence. So that's the purpose of AI. You then have a nice big blue circle that's generative AI, and that is generating new content. And so inevitably, that's our LLM, that is generating new content. Now, what does it cross over with? Well, it crosses over with what's called foundation models, which is your green circle. And that is massive AI models that are trained on enormous quantities of very broad and unlabeled data. Okay. And these act as kind of a versatile foundation. That's why they're called foundation models, because they can be adapted, right? And fine-tuned for a wide variety of specific tasks downstream. And so that's where it crosses over with your generative AI in order to create what's in the middle, which is your LLM and your GPTs. So there is a distinction between the LLM, which is your large language models, and your GPTs, because there's just GPT is a type of LLM, which is your generative pre-trained transformers, if you don't know what they stand for. But bottom line is there are different types of GPTs, different types of LLMs, and basically it's a kind of a read-write idea, right? So the I/O in computers, right? In and out, read, write. It's the same concept in LLMs. However, the first LLMs, the earlier LLMs were the complete package, read, write. BERT, for instance, from Google, very good at deep thinking and thinking about what you're asking it, and then it will give you a complete answer. But interestingly, the GPTs, which is the flavor of the years, I guess now, with GPT as well, Chat GPT as well as Gemini. So those are more on the right side, writing. So they're called autoregressive, LLMs. And so they just keep appending from left to right the next word that's appropriate for when it's writing to give you an answer. So that's a way crazy oversimplification. I'm sure Ernest is just freaking out here, but that's just kind of an idea of what your GPTs are. Okay. And that's what we're working with. And so of course, immediately you're all thinking, come on, there's some risks to LLMs, and absolutely There are. The first one, of course, is everyone, I would imagine, especially Sarah, who is very connected to the arts. I would suspect her concern of all of the creative writing that was absorbed into the training of the GPTs was probably not permitted by the authors. And so that's a very big area, something we have to deal with. So that's privacy and the leakage of it and whatnot, data privacy and leakage. Of course. The next thing that comes to mind, of course, is hallucinations. That Sarah also brought that up, and that is it believable? Is it all believable? No, absolutely it is not. And there's actually a disclaimer at the bottom of all LLMs that say exactly that you can't believe everything it says. The next thing that's brought up, and we'll talk about this, of course, is bias and discrimination. So clearly, if it's a bias going in, it's going to be a bias going out. You know the saying, garbage in, garbage out. Well, that does not change. Okay. Over reliance and misinformation. That wow, there's a topic that we could talk. You could have a whole workshop on that. But in the terms of now we have this wonderful tool. I think it's a wonderful tool that I use a lot and I think is great. Well, there are some risks, and that is, of course, over reliance, and then the problem of perpetuating misinformation. Sycophancy, which means it telling you you're great. I love it. I'm going to be very open. I love it. Oh, what a wonderful idea, Pascal. I'm like, oh, I thought that too. So and that's the reason they do it, right? Because it rewards you. It makes you think, wow, what a creative, wonderful thing that you wrote in as a prompt. Yes, of course, you do need to be very careful about that. There's a purpose for it, and the purpose is to encourage you to use it. So definitely, as long as there is a clear understanding that you are benefiting from it because it's like mom. Mom always tells you you're wonderful. It's great. Everyone loves that, right? So, but you do need to realize that it's mom that's telling you you're wonderful, right? And so, as long as you can gauge that, then you're okay. And I think it's the same with LLMs, and we can talk about that. The synthetic consensus, there's the tricky bit as well, is that because it's coming from ChatGPT, you think it's been trained on all the data in the entire world, and that includes every person on the planet, and therefore, what it's telling you must be in agreement with everybody else on the planet. And couldn't be further from the truth. So certainly we need to be aware of that. So bringing it into today's topic, we can talk a little bit more in terms of the biases that we really clearly need to be aware of. And definitely, as you know, if you're working in the area of clinical algorithms, you really do need to be very careful about the data you're training on, because it could be biased to begin with. So, for instance, I have a wonderful algorithm that I trained that's being commercialized, and that's in hemophilia. Well, the biggest problem with that is, as you know, it's a sex-linked genetic disorder, and it's mostly, not always, but mostly male. So, of course, all my data is male. So, how do I deal with that so that when there is scans that I'm processing that are for women or female, that it works just as well, because that's the problem is if I only train on male, well, the female, it's not going to work as well, right? So there's a huge drop in performance. So anyway, there's a perfect example of where we need to be aware of that. And so inevitably, the historic data is going to be a problem. The labeling is going to be a problem. So and on and on. And today's not the topic to talk about biases. We could do an entire workshop on that, but I just thought I would bring it to your attention. That is certainly something that needs to be brought into light when you're using AI, especially for this topic where it's going to be giving you some potentially guidance and some background information that may be useful for you. Please bear in mind that the algorithms are only as good as the data they've been trained on. Okay, so just keep that in mind. The confirmation bias, which I say I love. Well, we do need to be careful about it, inevitably. And if you look at all of the different algorithms that are listed here, that are all the ones that we are using currently, you can see that you have a huge increase in terms of compared to humans, which is 39%. The reinforcement, you have an additional like 50%, like right for some of the top ones. So just keep that in mind. I already talked about it. I love it, but you definitely need to tone it down if that is important to you. And you can do that in your personal settings. You can say, hey, when you respond to me, chill. Like don't always tell me I'm amazing. Just bring it down a notch. And you can certainly do that, which is just something for you to understand when you're using this. So this is a wonderful paper that came out in 2024, and it's just comparing AI-generated responses and compare it to humans. And of course, we could talk about this for forever, right? But it just kind of showed that people preferred the empathy generated by a GPT as opposed to what human physicians wrote, right? 72%, 73% of the time, right? Okay, so first and foremost, be careful. This is a study and it's comparison word and word, right? And so I love the part about Sarah when Sarah was talking about the challenges of body, right? So she wasn't just talking about words, which we are talking about today, but we do realize that we communicate more than just by words, right? And so body language, et cetera, is very important. So this study clearly excludes that, which is very important. So yes, very interesting that it showed that computers can generate text that people enjoy, and I believe it because and we'll talk about why that, but this was just a lovely study to share that you guys can dig into, and there will inevitably be many more of these that are coming that people are currently doing the research on. Okay, so what's our framework? I'm going to speed this up a little bit because I want to get you guys right into the software. But essentially, clinical judgment always comes first, and then we use AI as a supporting tool. That's what we're going to continue to reinforce today in the workshop. And then obviously a patient-centered lens and the equity and safety check. It completes the circle. So that's what we've adopted today for this workshop. Are there other ways of doing it and all that stuff? Maybe, absolutely. But this is the framework that we're adopting today. Okay, for today's talk. A lot of these we're gonna talk about in practice, right? So using LLMs, why would you? What are the uses, right? So simplifying medical texts, no surprise, fostering the communication and shared decision making. That was addressed already by Sarah. Better understanding and empathy for patient background. We're going to show some examples of that. Structured clinical reasoning, right? So just organizing information, helping you potentially with differential diagnoses, and maybe clarifying, sometimes your thought processes. And then, of course, the irony is avoiding confirmation bias and promoting humility, right? So in this case, the LLM's telling you you're wonderful, that's fine, right? But in this case, what we want is, alternative explanations and uncertainties, which will help, all healthcare professionals to question the assumptions and most important to remain reflective. Okay, so that's what we're talking about today. So I'm going to encourage you now to please, if you haven't already, please go to our website. So we created this for you for this workshop and of course beyond. And this is kind of a sandbox for you guys to play. Okay. And I'm going to take you right there, and I'm hoping you see my screen, which you should. So this is the website for you. The other one was Civil Discourse, but they're similar, but the what you do in it is different. Two buttons: start learning and practice. We're going to start with the start learning, and what this does is it goes through examples, right? So you have here. I didn't even count 7 examples that you can go through. And when you click on one of the examples, as you can see, you can go through all the examples. You'll get a little what you'll learn here. So what the objective of this example is going to provide you. Okay. And then then you run through, this is the story, the text that is provided. And then if you run through the live interaction, it will give you back what an LLM can provide you with all that information up top. And then it will give you a little, this is the reason, this was the teaching moment is at the bottom. Okay. But what this does, all of these learning moments is an opportunity for you to just see what LLMs are capable of. And all we're doing is giving you some kind of key examples of where maybe you would apply it. And what, in terms of structure, and this doesn't mean that this is the only way you can do it. Of course not. This is just a way for you to get started, right? To understand the use of LLMs and how they may work or may not work. When we move to the practice, you'll see up here, the little button over here, the practice. What you'll do here is, once again, you have different examples up here, and it tells you what this example is the objective of this example, and then it runs through. But you'll see that this one here is a little more hands-on, that when you run the prompt, actually, let me get to, yeah. So for instance, this one here, you'll put in a prompt, and then you'll click here and it'll say, hey, I'm asking you, the LLM, to give me a score. How am I doing here on this prompt? And by playing around with this prompt, you can improve or actually make it worse, the prompt that's popping up, okay? And then you end up with running that prompt. So this is the score of the prompt, and then you run your prompt below, and it will give you the answer. And then by playing around with this prompt, you can change the score and then see how the answer is down here. You can imagine this is our suggestion, but you can do you, right? So depending on what's important to you, when we generated this score, that this is what we decided, what we think is important, but don't forget, this is you, right? So you can decide how to generate that score and get your LLM to generate the score. And then, of course, the prompt that comes in afterwards. Okay, this is just an example. So there we go. I'm going to leave it at that because I'm going to let Aria jump in. If you have any questions, just put it in the chat. I'm going to be monitoring the chat. Aria is going to walk you through a few examples, and then we're going to let you work a little bit on your own. Not too long, don't worry, because I know how that works, right? I'm not going to let you guys go for 15 minutes, and we'll be very short. We'll give you an opportunity to work a little bit on your own, and then we'll come back and talk about it immediately. Aria, my friend, you're on.
Okay, so we're getting to the more practical section of our workshop now. And so if you switch to the practice tab on the website, mh.softx.ca/activities, here we have the examples that are actually connected to API of an LLM. So you can see in real time the answers that you can get from the LLM. I'm going to explain the first example just to get you familiar with the environment and UI. And then I'm going to give you some time to work on the next examples on your own. So for the first example, we have the scenario of language barrier, which Sarah also talked about in the clinic, which imagine we have a patient that is not fluent in English. And so we need to explain the diagnosis, the treatment, everything to the patient in a way that they understand and they can comply with. So here we have what you'll learn, which is pairing text-based prompt and a visualization to show how we can address communication barriers like limited English through nonverbal means. And in this example, we have a patient who is diagnosed with H. pylori, and they have the associated gastritis. And our treatment plan is to do a regular triple therapy, which is PPI and antibiotics. Like it could be a variety of antibiotics like amoxicillin and other antibiotics. So what we have here is first our initial prompt to ask DLM explain H. pylori gastritis and the treatment plan in simple, clear English using short sentences and non-technical words. So this is our first thing that we're asking. Make sure the explanation is easy to understand for someone with limited English. This is the second one. And our third point is include a way to check understanding and encourage the patient to tell me if anything is confusing or not clear. So we have three parts here. We hit generate and it's generating live. Here we have understanding your stomach problem and treatment. So we already see that it is written in simple words. And what we have here is what is wrong. You have a problem in your stomach. There's a small germ living in your stomach. And for your treatment, we will give you 3 medicines to take together. 2 medicines will kill the germ. 1 medicine will calm your stomach. And it will take 40 days to complete. So we have all the explanations here, but I will when I see the answer, I might think, okay, I don't have any instructions on how to deliver this answer. So this is also what we wanted to show here is that these prompts are just examples, and we can expand on the prompts here based on what we think might be needed in the clinic. So here, for example, I want to ask, uh, actually, I want to add it to the beginning of the prompt. Uh, First, give me detailed instructions on how to deliver this with empathy. And then I run the prompt again. So here I have a better response. So I can get prepped for it, like pause and prepare the environment, sit down, if available, request a trained medical interpreter, silence your pager if possible, recognize the yes, yes pattern before you begin. So I know I'm getting prepped for this. Frequent nodding, so it's saying that if the patient only says yes, yes, it might and only nods, I should be aware that they might not actually understand this. Uh, and there are some actually recommendations for me, like use short pauses between sentences, keep your face open and calm, gentle hand gestures, all of that, and then it goes through a very detailed explanation and step by step guide for me on how to deliver this. And it actually is giving me some sentences, some sample sentences that I can use or what not to say here. And after this, what is interesting here is that I can actually ask the LLM to give me a visual aid specifically for this patient, for this scenario, to help me explain the patient what's going on. So we have this prompt here that is so the first thing is stomach infection, and the second one, so number one is just showing the infection. The second one is cause of symptoms for the patient to be informed that it is caused by bacteria. And the third one is our treatment steps. So we have three medications. And of course, the fourth one is that it is going to take 14 days and they have to take the medications day and night. So with that, we're going to move to the second example, which is about translating complex medical language. So here, this example is for situations when we have a very complicated technical radiology report, and we want to explain this to the patient. And this is where LLMs can help us find the right words and the right structure to explain this to the patient. So here's the report. Starts with there is a 6 millimeter ring enhancing lesion in the left frontal lobe with mild surrounding vasogenic edema, and it goes on and on. And then we can see, okay, if we give this to the patient outright, then we can see the baseline score based on the criteria that we have, which are clinical accuracy, so we have a good score for this. Clarity, it is 7, and empathy only 1, and shared decision making 2. So we lack scores on empathy and shared decision making. And then there is a prompt to make it better. And I'm gonna pause for a few minutes so that you can go through this example, the second example on the practice tab. And if you can find creative ways to make this prompt better, or you please share your experience in the chat. So I'm gonna mute my microphone now, but I'm gonna just go through the example silently as you're doing it.
Thank you, Aria. While you guys are playing around, I can answer, or we can answer a few questions. Janet has put a bunch in. There's also the original question about dealing with the emotion of personal issues when there's a trust issue with AI. So we can do that. But Janet has a few excellent questions that have come up immediately from this. So while you guys are working in the background here, we can answer a few. So how is the patient going to respond or give comments? And then the last question is, the technology advances and the exclusion of patient input continues now by design. So excellent comments because you're right. So in this case, this technology, the way that we are presenting it is actually in one direction. You're absolutely right. And that is as a tool, as an aid for a healthcare professional in order to interact with their client, patient. So you're absolutely right. In this case, the focus today is on how the healthcare professional is going to deliver. You're absolutely right, though, that in return, the patient would like to be part of this process as well and communicate. And interestingly, I think that's going to happen. So this is just a personal reflection, just because I'm in the space, but I absolutely think that it is going to be bidirectional at some point because the most patients have a cell phone and do have also a smartphone and do have access to a chat GPT as well. So their ability to formulate questions for their healthcare professional is going to be much easier than it used to be, as I'm sure you've all heard the expression, Dr. Google. Yes, patients do Dr. Google all the time, and that was just with Googling, searching the web. But you can imagine now it's not Dr. Google, it's Dr. Gemini or Dr. ChatGPT, where they're asking these questions directly to an LLM to ask their healthcare professional. So I believe that it is going to go both directions. But you're right. In today's presentation, it is more from the perspective of the healthcare professional. So how is the patient going to respond or give comments? Well, they're going to respond as best they can, and then if they wish to use their phone during the session, they most certainly will be permitted to do that, and that may actually be helpful. So we'll have to see. I am certain people already use it. My mother does, and she's 89. And she's actually hospitalized right now. I'm going to pick her up to take her home from pneumonia in the hospital. And so when she's in the hospital, she has her phone all the time, and I'm constantly texting her. And she uses Gemini to ask questions about treatment and to communicate with her, circle of care in the hospital. So just to say, it is already happening. And then I think the rest of the questions kind of touch in that. So the broken English, if they had it for years and may feel infantilized. I mean, sure. I mean, inevitably some of those perspectives, the LLM is not going to be helpful. So there are limitations to what this tool can do, and hopefully not make things worse, which I think maybe you are insinuating. Um, so you guys have been working, I'm not going to say feverishly, probably, but you've been working on, in the background here. Um, does anybody have any questions directly? Because I just want to be mindful of time as well, because this is a busy time for, post work and getting home for dinner and stuff like that. But does anybody have any questions? Janet, if you have any other questions, feel free to throw them in there. Absolutely. But if anybody else has any questions, please just drop them in the chat or any comments on their experience using the LLM, please do that as well. But maybe what we can do, I'll leave it at that. Unmute, feel free to unmute and just say. Everyone has the right to say something out loud. I mean, maybe Anthea Grace, maybe you can step us through some of your aspects of it. Does that sound good, guys?
Yeah, sure. I'll share my
Awesome.
screen now.
Yeah, thank you.
Can you see my screen?
It's coming. Not yet. There we go. Got it.
Awesome. So I'll be walking you through an example that I'm sure many of you are familiar with, managing patient frustration. For this one, there isn't a response to score first. We have the scenario, and then we are going to ask the LLM to create the response, and then we can mess with that a little bit more. So a patient has waited 4 hours in the emergency department for a CT scan due to high volume and trauma cases. They are visibly frustrated and they say, "This is ridiculous. No one cares how long I've been waiting." So the main priority here is obviously de-escalating the situation. You don't want the patient walking out of the hospital and deciding that it's not worth their time. You want to make sure that they feel understood and also be fully transparent about what's going um, on your own end as to why there's been such a long delay. So this is the prompt that we have. Respond to an upset patient who is frustrated about a long delay for imaging, acknowledge their emotions, explain the reason for delays without defensiveness, and communicate next steps clearly while preserving trust and de-escalating tension. So I'll load this prompt and show you essentially what it says, and then I'll let you guys mess with it a little to try and improve it a little. So it does a good job at the empathy point. It acknowledges the patient's feelings. It says, "You haven't been forgotten, but we understand that it feels that way." It explains pretty well what's been going on in the scenario with the trauma cases and the emergency cases. And then it refers back to essentially next steps to ensure that the patient knows what's going to happen next. And then asks about pain or discomfort or doing anything to make the patient feel more comfortable. So if we ask for scores here, it gives us a score of about, let's see, 8.5 out of 10, which is pretty good. It's, like I said, it has very good empathy. It's pretty clear. It performs relatively well in the clinical accuracy. It does avoid any detail about the patient's condition or triage status, which can be improved on. And then also, it doesn't perform as well on shared decision making since the patient doesn't have any agency here. So I'm going to mute myself and go through and try to improve this. And I invite you to also take a stab at this as well. And then if you have any questions or anything that you want me to explain more about the scenario, I can answer that.
Thanks, Anthea Grace. So yeah, please play around and we'll watch as you're speaking. I thought I would take this opportunity as well, maybe if Sarah would like to take a stab at that question that came up at the very beginning, which is how do you think it was the last topic that we were talking about, your
Yeah,
topic.
I
Some
have thought
patient
about
needing
this
trust.
a
Yeah, okay.
lot, just because we know that students do this, which is why when we design chatbots, some of them have been programmed. If the student starts to divulge things, or it may warrant them needing to seek more mental health support, it's the chatbot is prompted to do that, recognizing that that there's a lot that can be processed using tools like this, but ultimately the individual needs to connect with a person. We as human beings, I think that's something that is an interesting time, that ultimately, like, what we're looking for is connection and actually validation and being seen. So from an emotive aspect, it provides a way to fill a gap. From my perspective, it needs to be designed in a way where it fills the gap, but then prompts a pathway to being able to have the individual, because ultimately a lot of the processing that's involved needs to happen interpersonally, just as the way we are designed as a species is that a lot of this transformation occurs when we can actually do the thing and find the courage to do the thing, and not necessarily do it perfectly at once. So the tools that we're trying out here are really interesting to me, because they do have potential to help facilitate a kind of learning that we're hoping. And also there's a gap in how to get individuals to be able to communicate from technical world to everyday language. We know that exists, but it's also because historically there was no value, like it didn't matter. You just kind of got told. But now we're at a different point in history where you actually want to be able to have the person understand and be with that person. So the profession of medicine has changed, but there's a lot of things lagging in terms of our education systems and our systems in general. And so also this trust with AI is because it's designed to validate you. So that's a fascinating thing in itself, is that, again, most people are looking for some kind of validating, supportive environment. And the machine is designed to do that, but it can only go so far as so as not to reinforce again, because you don't want it to do confirmation bias. You do want another active participant that can also challenge the person so that they don't get stuck in essentially just rehashing it. Because arguably, that's just simply re-traumatizing the person to stay stuck. So that's how I would talk about that now. And again, it's a fascinating place we're at, and there's so much potential for this to facilitate arrival at a place where it is going to actually enhance and improve a lot of different things around education and mental health support and mental health care, and actually just care in general, like healthcare in general.
No, that was excellent answer, and you brought up a very interesting point about connecting. Ultimately, the path of the patient or client, depending on how you perceive it, is ultimately looking for connection. And I can say I work in indigenous communities in Costa Rica, and our work there, it's interesting that the use of technology is accepted by all. So all, like meaning the providers and the patients or the community members. Everybody uses technology and accepts it. There's no doubt. But it's interesting that the delivery of it is exactly what we're doing here. We're learning to better deliver, improve access to care, all that stuff, education, everything. That's, making our job easier and better and more widely distributed. Fantastic. And the patients on their end, they all have cell phones, or most of them. They'll have at least a cell phone per family, and they absolutely love it and use it. That's not the issue. The issue is exactly what you said, is they're still expecting to connect. So the technology is actually for them, they love it and they use it, and they have lots of purposes for it. But ultimately, they still are looking for and wanting that connection. So that has not changed. That's interesting what Janet was saying. Those questions that Janet brought up, is that's what we're observing, is that, we can put in all the technology we want, and it's absolutely fantastic from our perspective of delivery. But ultimately for the patient, they're still absolutely looking for connection, and depending on their culture, depending on their tradition, they're expecting that as well. Even if there's technology, doesn't matter, that hasn't changed, right? So it's very interesting. It's fantastic. Great answer.
Yeah, and when I've been playing with it, what this is also, it's interesting what this is doing is not necessarily mitigating or solving a problem. It's actually making us more specific around what the problem actually is. And one lovely thing about this is that currently, in Canada, we're in these resource constrained environments where it's really difficult to deliver compassionate care when you're resource constrained. And this can provide a buffer for that, but then ultimately it's still highlighting that the fact that we need a buffer to begin with is pointing at a bigger system issue or system issues.
Absolutely. Yeah, agreed. Anthea Grace, you want to give us a little summary of what you've achieved working in the background there?
Yeah, so I added in mainly a clause to make the response shorter, since I think in any clinical setting, you wouldn't want a 3-paragraph response to try and get through. That wouldn't be very efficient. And I was able to include that without reducing the score much. And then I also added in first a sentence to directly refer to clinical information available about the weight or the patient's condition, to try and increase the clinical accuracy metric, but that hasn't improved much. I think that might have more to do with the information available to the LLM and less to do with the prompting, though. And then I also added in a prompt to ask if the patient would like to discuss their care and if they have any questions specifically. And in one of the other iterations I ran, that was able to increase the shared decision making to 8. It's been flip-flopping between 7 and 8, and I haven't figured out what is the actual difference.
Awesome. You know what I really like about this as well, and you've demonstrated it well, Anthea Grace, as well, is that when you look at the score, for the same given score, you can have a different balance, right? Of where the strengths are in the answer. And I think what that shows is there's no right answer. That's what I like about it, is that everybody can work with this and decide what's the right answer for them because they like the different weighting of, you know, their answer that they worked on with the LLM, and they decide that's what fits me. You know, that's me. You know, that's the way I would like to deliver it. So it is there isn't one way. You know, it's not like everybody is going to get the same answer, which I think is also a concern, is that if everybody's using LLMs, that everybody's going to give the canned as in, you know, the expression in the can response, right? And that's not true. I think if you learn to prompt, then you know there are many equivalent good answers that can be shared. So that's fantastic. Thank you. Does anybody else have any questions? I'm just being mindful of time. Does anybody have any questions that they would like to ask? Anything they'd like to share from their experience in the group? No, everybody good? No? Okay. Well, I would like to then ask Sarah if she has any closing comments.
Yeah, I've played a lot actually with different LLMs as well, like with the same question and then just having conversations back and forth. And again, it is an exciting time where there's this new technology that is offering a potential avenues for solutions of gaps that we know very well exist around human empathy, around also just the limitations we have as human beings, and where we are at currently in terms of the histories of our structures and practices. So what I hope is that we continue to just be open to the idea of it. And in the arts world, what it is that people are thinking about, how do I want to use this tool where I continue to preserve my own independent creativity, where I don't become reliant on it to think for me. It's something that, I tell a lot of my learners is if it's thinking for you, that's a problem. But if it's getting you to think more or more broadly or think more critically, then that's when you can see it being something that's supportive in terms of allowing your own skill development to continue to grow. And I'm really enjoying what you're doing, Pascal, with the work and the research, and and I thought it was just very timely our paths crossed because
Yeah, no, absolutely.
this is really at the top of my mind.
Oh, thanks for coming. So there's a funny little anecdote that I give for exactly what you just said in terms of thinking for you. So I do a lot of sport, and I know you do now. And so I coach powerlifting, weightlifting, all those strength sports. And so an example is if you want to improve your bench press, so you want to get stronger in bench press, the comparison would be that if you have AI that's going to help you, you know, improve your bench press. If you go to the gym and you watch Aria do bench press, that's really not going to help you in any way. And that would be similar to getting AI to do it for you or thinking for you. You're just not going to improve. So, you know, in terms of that's just an easy way of, giving an example that, you know, how AI is going to be useless to you if they're doing it for you. For the example of a bench press, you can relate to that you're never going to improve watching someone else do it. Sarah, absolute pleasure having you. Thank you very much. Hopefully we'll see you again at a future event. And thank you all for joining. That was fantastic. What a great workshop, in my opinion, my humble opinion. Thank you very much, Aria and Anthea Grace, for helping me host today. That was wonderful. And I wish you guys all a fantastic week, because it's Monday. What a great start to the week. Thank you all for joining.
Thanks, everyone.
Look at that timing too, 6:30 right on. Amazing. Thanks. And if you have any questions, of course, feel free to reach out to us. Absolutely. I'm sure Sarah as well would be happy to get your questions. Thanks for joining.